Okay, so welcome everybody to Grand Rounds. Today we have two conferences. We have the Lancet Commission on Public Policy and Health in the Trump Era, presented by Dr. Carrasquillo, who is currently the Scientific Director in Internal Medicine Resident in the Presbyterian Hospital Behavioral and Community Shared Resource Sylvester Cancer Center, and he has been working with University of Miami and Jackson Health System since 2009, and Dr. Balen, who is currently a research assistant professor in the Division of Medical Oncology with the University of Miami, as well as Associate Director of Research and Leadership. She obtained her Doctor in Science degree in Social and Behavioral Sciences from Harvard University in 2014, and her Master in Science in Public Health and Global Epidemiology in Emory University in 2009. So welcome, and thank you very much for being here.
So I am neither Dr. Carrasquillo nor Dr. Bailey. My name is David Himmelstein, and I'm going to start us off actually today.
Then let me introduce you. I apologize for that. I understood it was the first conference of the Lancet Commission, but well. So we have Dr. Himmelstein. He completed his residency training in internal medicine in Highland Hospital in California. He is an adjunct clinical professor in medicine in Albert Einstein Medical College and distinguished professor in public health in Hunter College and the Graduate Center at University of New York, and also a research associate in the Public Citizen Health Research Group. Currently the chair in the Lancet Commission on Public Policy and in the Health in the Trump era since 2017. And since 2010, he has mentored multiple medical students, public health students, residents, and fellows research projects. So welcome, and thanks for being here.
Thanks for having me. Let me start out by sharing my screen. I should also say that before coming back to New York, where I was born, I spent 30 years at Harvard Medical School, and that medical school is still mourning the loss of Dr. Carrasquillo, who was our best fellow ever in general internal medicine. So neither Dr. Woolhandler, who's going to be speaking a bit later, nor I have any conflicts of interest to report. We're going to talk today about this Lancet Commission on Public Policy and Health in the Trump era that Dr. Woolhandler and I have co-chaired. There are a number of others who have made major contributions to it. Dr. Carrasquillo, Dr. Bailey, who are going to be speaking today, who are at the University of Miami. 29 others have also been members of the commission, a broad group ranging from very senior scholars to the energetic younger people who have done much of the work. The commission is set to publish its report, which will appear on February the 9th in the Lancet. It's a 30,000 word report with 24 figure tables and panels and 11 topic focus sections. I don't propose to go through all of those today. We're going to talk today about some selected aspects of it. The Commission's report reviews the major failings in health and social policies that preceded President Trump's ascendance, and the health relevant actions of the Trump administration, which we fear have been, in many cases, very health damaging. And the Commission has a long series of recommendations for executive and legislative actions for needed reforms. Let me just start out by setting a bit of context, given what we're all going through now. About why our country was so vulnerable to COVID-19. And our assessments are that the background was deteriorating health status in our population, weakened public health capacity, widening inequalities, and a crumbling and racist social safety net in our nation, and a wasteful and really profit-oriented healthcare system that fails to meet many needs. Prior to the pandemic, the progress on mortality in the U.S. had essentially halted for nearly a decade. So we'd seen steady progress up until about 2010, 11, and since then virtually no progress on mortality rates overall, even prior to the pandemic. Angus Deaton and Ann Case identified working class whites declining economic opportunities and social status as a principal cause of rising mortality in our country, very well-known essays that they published, but they neglected the longer standing and graver effects of economic privation and racism on indigenous and Black Americans, and all of those things factor into the deteriorating status in our country. We've seen recently reported out of the JAMA deterioration in blood pressure control nationwide, really again unprecedented since these data have been kept in this country, and this goes broadly across populations, though the uninsured and people of color have the worst control of their blood pressure. And this graph showing a comparison in longevity between the US and other nations that we would compare ourselves to, showing that we were middle of the pack until about 1980, but have fallen steeply off the curve since that time. And now our life expectancy trails most other developed nations by 2, 3, 4 years. And the excess mortality of Americans compared to other nations has been mounting, so that in the most recent year for which we have data available, we estimate that about 460,000 excess deaths occurred in this country that would have been avoided had we the mortality rates of the average of the other G7 nations, the other major economic powers. So we're losing, even before the pandemic, about 460,000 people each year. And here we've separated it into different racial and ethnic groups. And you see that American Indians and Alaskan Natives in orange at the top have the highest mortality rates, and African Americans second highest, but white and Hispanic Americans have higher death rates at all age groups until the oldest that exceed those of the other G7 nations. So we have a broad crisis in excess mortality that cuts across virtually every group in the US. And estimates are that COVID-19 has sharply reduced the life expectancy, particularly of Black and Latinx people in this country. So the life expectancy estimate is that white non-Hispanics' life expectancy has fallen by about 0.8 of a year, while that for Latinx persons by more than 3 years, and Black people about 2.5 years. Life expectancy, interestingly, lagged substantially in the counties that voted most heavily for President Trump in the 2016 elections. We don't have this kind of data yet for 2020, but suggesting that the deteriorating health in these counties may have been connected with the impulse to vote for an alternative candidate. And life expectancy has not decreased or stagnated uniformly across the income spectrum. The poorest 1% of Americans actually saw a fall in their life expectancy between 2001 and 2014, while the richest 1% had a more than 3-year increase in their life expectancy. And generally, the wealthier people were, the more their life expectancy was growing during this period. Now, some other indicators of widespread problems, particularly in the Trump era: deaths due to environmental and occupational factors, which had been falling since the year 1999, took a sharp upturn starting in 2017, coincident with the relaxation of occupational standards, environmental standards, air pollution standards, and so on. And we've seen really not only no action, but reverse action on global warming that threatens rising sea levels. And we did find a picture of Miami that we thought was particularly appropriate to illustrate this point. US health expenditures also started to diverge from those of our neighbors or our comparable nations starting in about 1980. We were relatively similar as percentage of GDP in our health expenditures until that time, and our health expenditures have grown much more rapidly since then. And the Commission concluded that the fundamental problem behind this raft of health deterioration or stagnation was the adoption of a neoliberal policy framework by our leaders, both in the Democratic and Republican parties, that rely on the markets to regulate themselves, that paints government as largely incompetent and seeks to cut taxes and regulation, privatize public services, and that seeking equality is viewed as counterproductive and more morally corrosive. Now, I guess Ronald Reagan illustrated this with his famous quote, "The most terrifying words in the English language are, I'm from the government and I'm here to help." But Bill Clinton kind of mirrored it when he said the era of big government is over. And during the Clinton administration, many government programs were sharply cut, and we're now reaping the rewards of those cuts in the current era. Milton Friedman, one of the main theoreticians of neoliberalism, said many years ago, few trends could so thoroughly undermine the very foundations of our free society as the acceptance by corporate officials of a social responsibility other than to make as much money for their shareholders as possible. And we've come to rely on corporations to carry out the basic functions of our society, and unfortunately, their officials have proven Friedman correct in not taking on the social responsibilities that come along with the devolution of responsibility to them. Now, our weakened public health capacity is also a reflection of this trend. Since 2000, the proportion of our health spending devoted to public health has fallen from over 3% to under 2.5%, and we've noted at the bottom that Canada spends more than 6% of its health budget on public health measures, and that's reflected in the falling public health workforce, which declined 20% between 2008 and 2016 and left us so poorly prepared to tackle the current pandemic. And President Trump further weakened pandemic response after he came into office. He instituted a hiring freeze at the CDC that left 700 vacant positions, abolished the Global Health Security Team and the National Security Council. 1,600 government scientists have left positions since January 2017, and many key science policy positions have remained vacant. Most recently, he defunded the World Health Organization, which has been so critical for responding to the pandemic around the world. And meanwhile, the tax rate, which has fallen sharply on the very wealthy in our country, you see, back in 1950, the richest 400 Americans paid 70% of their income in taxes. That's down to 23%. And meanwhile, the poorest 10% saw their tax burden increase from 16% to 26% of their income. So the poorest people now pay a larger share of their income than the richest people in our nation. And we've had a huge ramp up in the number of people in prisons. Here, the number in pre-trial detention. These are people, of course, not convicted of any crime and yet held in jails and prisons around the world. And we have much more imprisonment than even the most repressive countries that we would think of, Russia or Iran. And social distancing in prisons has, of course, been a virtual impossibility. Here, a view of one California prison. And a result has been huge epidemics, not only in prisons, but in communities spurred by those prisons. So a study in Illinois found that the cycling in and out of prisons, both by prisoners and by prison staff, resulted in about 15% of all documented COVID cases in Illinois having their origin in the Cook County jail system. And a study we published in the Annals of Internal Medicine this summer showing that while we recommend isolation and quarantine for many, particularly Hispanics, Native Americans, and Blacks, the living quarters they occupy make effective quarantine or isolation impossible. There just aren't the bedrooms and bathrooms to allow one individual within a household to isolate from the others. And while we've seen particularly high death rates in the African American, Native American community, a reminder that the death rates are from things that we can do something about as physicians. So a third are from heart disease, much of that inadequate treatment of hypertension and hypercholesterolemia, cancer, much of that inadequate early detection and treatment, renal disease, of course, largely from diabetes, and hypertension, stroke, the same. So interventions that could be made and aren't. I want to turn now, if Zinzi Bailey is available, to ask her to speak. Is Zinzi with us?
I'm here.
Okay.
Am I able to share my screen?
I think you are.
Okay, great. Thank you. So really, I'm going to be continuing this conversation and focusing in on one of the key parts of this report, which is really highlighting the history. Give me 1 second. Let me get my right screen up. And highlighting the key points of our history, many of which have been identified already, but this gives us more of a sense of what has been happening, especially with regard to considerations of white supremacy and the legacy of essentially America's original sins. So, here we go. So essentially, I don't want to repeat all the things that have already been said, but I do want to set a context, right? Essentially in December of 2019, when we're starting to get that sense of there's something going on in China, there's some kind of disease that we haven't really put a eye to, we haven't really figured out what this pneumonia of unknown cause is. From that time, we have been experiencing a range of different kind of dog whistles regarding the origin and the progression of this disease, right? And by April, the United States had swiftly become the epicenter of the COVID-19 epidemic. This has changed over time, as we have noted. And I would argue that some of the more recent leadership vacuums within the current administration, that's not necessarily the focus that we necessarily have to have, but we need to also think about the foundation and the deep structural inequities that exist in the United States, and see how that has set the stage for our current situation, right? And I would say specifically thinking about racism and thinking about the systematic dismantling of our social safety net, especially since the 1980s, as being a policy recipe for American structural vulnerability to the impacts of this pandemic and future pandemics, to be honest. However, COVID is really not operating on a level playing field, as I'm saying, right? So like, no matter what we do, so we have a vaccine, and I am very excited about that and how that is going to change how we've been able to approach this pandemic and be able to relieve many of our health care workers and be able to address some of this fatigue that we have had dealing with this pandemic. We're still operating on an uneven playing field. Back in April, we noted that while COVID-19 is indiscriminate in its transmission, its propagation within a society steeped in structural racism will undoubtedly lead to disproportionate impacts among marginalized racial and ethnic groups. So there are a number of reasons why we talked about that with regard to incidents, hospitalization and survival regarding COVID-19. And now we're embarking on equity as we're talking about treatment and vaccination, and how that relates to previous relationships that we've had between communities and government and medical professionals. But the focus of this is more towards the policy element, right? So we can say that the US had a very slow and anemic response, and it has laid bare these structural inequities, right? And namely the racism, structural racism that has existed within this country for quite a while from its founding, right? So that racism is at the heart of a number of different things that have been showcased in 2020, including racialized violence. We are seeing the consequences of a dismantled social safety net, and we've seen the structural vulnerability of the country to infectious disease in many different ways. This is the same racism that the same structural racism that drives COVID-19 inequities also drives the deaths of so many at the hands of law enforcement and common vigilantes with impunity, right? So essentially, we're talking about intersecting epidemics of COVID-19, police brutality, and thinking about that impact on communities of color. As has been, already kind of stated, that hospitalization due to COVID-19 is 4 to 5 times higher amongst Black, American Indian, Alaska Natives, and Latinx people compared to non-Latinx white people across the country. And a lot of that is not just due to comorbidities, which we were very quick to go to, comorbidities or some kind of element of biology. But as we have gone along, we're talking about some of the key elements that are impacted by structural racism. We're talking about residential crowding and quality of housing. We're talking about employment and thinking about the distribution of low income kind of frontline essential workers. Those who are most likely to be in contact with people who are essential frontline workers are not necessarily the doctors and nurses, although they are definitely key to this. But we have the techs who might be in charge of bathing, a lot of the high contact situations, and they are paid much less and have less negotiating power around different things around PPE. Things here might be a little bit different than in other contexts, but there have been a number of issues regarding these kinds of elements within employment and larger elements of risk and power. Furthermore, there's been a lot of disregard for implementing appropriate infection control measures at high-risk work sites, including nursing homes, including prisons and jails, and that has been a fight to get those things up to par. And while we have made a lot of progress within the nursing home space and have led to a lot, it has led to a lot of accountability, I would say that while prisons and nursing homes have very similar elements of aggregate settings, we have been less likely to think about or accommodate or think of those in penal institutions as deserving. And so we can say, or we can think about the fact that COVID-19 incidence is 5 times higher in prisons than it is in the US overall, sometimes approaching 65%. And jail-acquired infections have been accelerating. And so essentially with considering the hyper-incarceration of Black and Latinx individuals, we're seeing that very particular communities are more at risk of developing COVID-19 simply from the exposure to correctional facilities. There's an emphasis like this hyper-incarceration that we have been a part of actually makes us very vulnerable to this and other pandemics. And I want to just try to speed up because I'm probably going to be going over. But the scar of racial hatred has grown through a long history of systemic racism that we're not necessarily going to have, we're going to solve within, you know, a PR campaign around vaccination and those sorts of things, but it's a long ongoing conversation and effort and campaign for our, to develop this level of trust and relationship building in order to have the policies that can support equity, right? We started this country through colonization and genocide, and that ideology continues to live through a lot of the policies that we continue to support, right? And we've, civil rights has been, it's not to say that we have not made progress. We've made a lot of progress over time, and there has been significant implications on the health of communities of color. However, there has been this backlash that continues into this current era against public programs or other things that were considered great programs before, when certain communities were excluded from citizenship. But as people of color came to be citizens of this country, the recipients of public programs are considered undeserving poor, which ends up being a code word or a dog whistle for Blacks, immigrants, a number of things. And thinking about, you know, blaming, for example, Black poverty on pathologies within Black communities. We can point to a number of different things. We can talk about the war on drugs that Nixon led, where he did not lead it in, you know, equally across the country. It was emphasized on in communities of color, particularly urbanized communities of color, that were experiencing the removal of industry in the same ways that we're seeing that in rural white America right now, right? There are removal of jobs, removal of opportunities from the urban core. And essentially, these communities were experiencing despair, and were met with law enforcement, right? And I think from that, a decade later, we can talk about Ronald Reagan's fabrication and rhetorical vilification of the welfare queen as this fictional, lazy, undeserving Black woman whose welfare payments were, as he implied, stolen from hardworking whites. So this rhetoric and action continues throughout our policies. 1994, the Violent Crime Control and Enforcement Act, authored by Senator Joe Biden, then Senator Joe Biden, and signed into law by President Clinton, gave further impetus for mass incarceration. Similar policies have continued under Bush and Obama. So this is an ongoing element of our structural racism, the different components of that, those policy decisions. So coming back to this Trump era, this has continued with the rhetoric as well as the policy. There have been kind of implementing cuts to social programs. There's a lot of evoking of stereotypes of freeloading people of color. There's a condemnation of Black athletes protesting police violence, sympathetic portrayals of neo-Nazis, other white nationalists.
You have 1 minute.
Okay, I'm wrapping up. Thank you. And so there's a vocal support for the inciting of white violence against people of color, right? There's no calming of those feelings, right? And so essentially we've seen hate crimes increase. We've seen a lot of the rhetoric increase, and the polarization that we have in this country has increased. Thinking precisely on the public policy element, rolling the efforts to roll back ACA and Medicaid would also be harming people of color as well as rural white America. So we're seeing that this has impacts on health. So I would urge us to think about the historical context of structural racism that brings the foundation and context to the current era. And with that, I will hand it off to Dr. Carrasquillo. Thank you.
Thank you. Thank you, Bailey. Thank you very much. And let me see if we can all see my screen, I hope. Correct?
Oh.
We saw your screen, but not the presentation, Dr. Carrasquillo.
All right, now you see it, correct?
Not yet.
No.
If you have multiple screens, you may need to share to check what's the screen you're sharing.
Yep, now you can see it?
No.
Yeah, but not.
Sorry.
So click share screen, the green button in the middle. You have to go to Zoom.
Yep, done this a few times. Give me 1 second. Let's try it again. There we go. Just hasn't given permission. Okay, thank you. All right. And we could see it now, correct?
Yes.
Okay, good. Thank you. I was up as part of the Lancet Commission report. I was asked to focus on one specific, what I call as a case study of Puerto Rico, an example of what Dave and Steffie, called neoliberal policies, but which I use the word right wing for, and how those policies have really affected the island of Puerto Rico. And I will have to skip a couple of slides to be a little bit quick on it. But the essential question, looking at 300,000 COVID deaths right now, it's a little bit interesting to think where we were 2 years ago, where we were focusing on 3,000 deaths, and how could a hurricane that hit an island really result in 3,000 deaths, second deadliest hurricane in U.S. history, and how it was allowed to happen, and the focus of neoliberal policies. To do that, let's take a brief history of Puerto Rico. If you could just humor me for a second. So in 1897, the island gained autonomy from Spain. Nevertheless, in 1898, U.S. troops arrived to liberate the island that was already autonomous in most ways from Spain. In 1917, Puerto Ricans were given U.S. citizenship as part of being drafted, making Puerto Ricans eligible to be drafted for World War I. And in 1952, it was established as a Commonwealth territory of the United States, ruled by the U.S. Congress. And, to answer many people's immediate questions, yes, Puerto Ricans pay Social Security, they pay federal taxes, they pay Social Security and Medicare taxes, they also pay state taxes, the highest state sales tax in the country. And like half of the Americans, including the current U.S. president, Puerto Ricans don't pay federal income taxes. The Supreme Court has again recently ruled that Puerto Rico is definitely a colony. It is a commonwealth directly ruled by Congress, unlike states or Indian tribes. So Congress makes all policy-making decisions for the island of Puerto Rico, and it can overrule anything. The island, there's definite corruption in the island of Puerto Rico, which is also absolutely real. If not, I can have you call my dad, and he will go off on the phone on who got arrested every day with you from government. But corporate corruption is much worse. Starting in 1900, when the currency was devalued, the local Puerto Rican currency was devalued by the U.S., allowing U.S. corporations to basically buy up most of the island at a steep discount, and really decimating their agricultural industry and replacing it with sugarcane plantations. In 1919, what's called as the Merchant Marine Act forced everyone in Puerto Rico to only get their goods in U.S. ships going to the U.S. ports, which is about $6 billion wealth transfer from Puerto Rico to the United States because of that act that, despite many, many attempts, is both opposed by Democrats and Republicans to overturn that act. And then it was Clinton in 1996 who wanted to end welfare and argued that ending welfare meant ending corporate welfare, but God forbid he would end corporate welfare in the United States, ended subsidies for pharmaceutical and other industries that were granted in Puerto Rico. Without those subsidies, industry fled from Puerto Rico, and you see a dramatic drop in GDP as well as lost factory jobs as an exact result of the Clinton policy of ending corporate subsidies. Since then, the island's debt problem started to grow massively. And then Wall Street got in on the action, started restructuring the bonds, and issued over $120 billion in bonds with hefty fees and nice payouts to Wall Street, each time to further worsen the debt crisis in Puerto Rico. There's been a lot of graft in this. UBS is one of the companies that got in and basically reselling their own Puerto Rico funds to Puerto Ricans, but in a way they couldn't resell them and violating many federal laws. And for the $11 billion crime, they were fined $27 million as an example of the corporate profiteering. And everybody's gotten in on making money off of Puerto Rico's debts. Some of our well-known universities, one that me, Dave, and Steffi know very well, has been part of that profiteering, for example. And so Puerto Rico hit the cliff. Basically $74 billion of debt, $53 billion in unfunded pensions, economy contracts by 15%, population starts decreasing, and nearly half the population living in poverty. So the first hurricane was when the island actually declared bankruptcy in 2016, and the US said not so fast because in 1984 we passed a law that nobody knows about that you can't declare bankruptcy. They put a federal oversight agency appointed purely by the US president, responsible only to Congress, not to the Puerto Rican people, that would basically control every single government agency and manage all of the income for the island of Puerto Rico. That was the first hurricane. The second one was what's been happening to the Puerto Rican healthcare system. Before, 40 years ago, it was like many Latin American countries based on primary, secondary, tertiary, and quaternary care at the medical school called Centro Médico. But then there were government budget cuts and rationing throughout the 70s. Federal contributions to Medicaid, I'll get to, started dwindling. And basically, it was getting worse, the government system. In the 1990s, the father of the governor that was just ousted a year ago had a great solution. The public system's not working. Let's privatize everything. Let's give over care to for-profit HMOs. And we're going to pay for it by selling all public healthcare facilities. And then we're going to get money from Hillary Clinton's healthcare reform, which never happened. As a result, you basically lost all your public healthcare infrastructure and did not have anything to replace it. And that created tremendous problems with access to care, long waits, payments to doctors very problematic. And you had no backup plan, but a really, really decimated healthcare system. So right now, 60% of the population is covered by Medicare, Medicaid, and nearly all of the health funding comes from the government, mostly the local government in Puerto Rico. Medicaid is treated very differently from the United States. There's a federal cap on funding, so expenditures about $3 billion. The US government pays only 11% versus a state like Mississippi where the federal government pays 73%. And the island basically had to finance all that through debt financing, which created a major, major cause for the cliff. For those of you that want answers to CME and MOC questions, the Medicaid program in Puerto Rico only covers 10 of 17 benefits, does not provide nursing home care, no home health care, and most people in Puerto Rico in poverty are not eligible to do that. And they pay doctors extremely, extremely low. $10 for primary care visit is one example. It has the lowest cost program in the whole country, pays about $2,000 per beneficiary in expenditures because it is a very, very skimpy program that provides limited benefits. Congress has provided temporary fixes, giving some funding. The latest was in 2019. Congress wanted to fund the program for $12 billion for 4 years. Trump said, not so fast. I only want 2 years of funding, and that's all I'm going to give Puerto Rico right now. So we don't have a long-term fix for Medicaid. The Reform Commission just suggested, even though it's a very chintzy program, slashing the funding even further of the Medicaid program, increasing co-payments, and their focus was really on fraud and waste, even though it's a really skimpy program as it is. Medicare is also very different in Puerto Rico. It has the highest Medicare Advantage penetration, but also has the lowest fees for enrollees, about $3,000 per beneficiary, less than in the US. And again, it's treated very differently. Disproportionate payments are not set to SSI, so the island gets really ripped off for a lot of money. And Part B enrollment is not automatic like in the United States. And the benchmarks used to pay the Advantage plans are much less, again, resulting in about $2 billion a year in shortchanging. And doctors have been leaving the island, obviously low income, about 15% of the doctors, but overall 10,000 health professionals, nurses, and other healthcare workers have fled the island in the last decade. Then the hurricane struck. And yes, global warming is definitely related to hurricanes. I won't go into it. And we had 3,000 deaths. Most of the deaths were not from traumatic injuries, but basically a very weak and crippled healthcare infrastructure. Total disruption of the healthcare system was what happened as a result of the hurricane. Really decimated the system. And unfortunately, when our president came, all he could do was throw paper towels at the island. Meanwhile, the Panhandle had a hurricane a few months later, and he's promising 90% reimbursement for recovery costs, while for Puerto Rico, arguing that the island needs to be self-sufficient and not dependent on the United States. And these healthcare problems continue throughout the island right now. We still have many of the healthcare system and infrastructure totally decimated that has not been rebuilt. And then we saw profiteering, whitefish, but many other egregious examples. But really, it's the long-term capitalism that's really destroying the island right now. The whole thing is to privatize everything because it worked so well for healthcare. The biggest one is the public utilities, the public healthcare system. When there was a growing movement to do sustainable, renewable sources of energy, the federal government put a stop to it. They've approved funding, but only if it builds on the existing fossil fuel electric grid that currently exists, and the contracts, no surprise, US corporations. The hedge funds have also done nicely. They're getting all the money from the state tax will now go to pay the debt that the island has. And in between, we got a governor that was ousted. We just elected a new governor there, like the US, extremely close, 33%, but it is the pro-statehood governor that got elected. And the question of statehood, there's been a lot of non-binding plebiscites. The last one just happened in November. 52% of the island says they want to be a state, but obviously the US government has ignored all plebiscites. Republicans, which are affiliated with the statehood party, don't really want it to become because it'll bring 2 senators or 4 if you argue Washington, D.C. should be resolved at the same time. So they're not going to allow 2 or 4 Democratic senators. The Democrats have traditionally been aligned with the Commonwealth Party, but they just want to stall and do more conventions to think of what's best for the island as well. And COVID did strike the island. 3% of the population has been affected, which is better than Florida. There were some very early blunders, but they did a really, really good job. They basically knew there was no assistance from the federal government. So they did a really good job of contact tracing, getting testing supplies from other countries, and really had clamped down. But then in August, that's when they started to really peak, when they started opening up the island again. Surprise, surprise. And now they're back to where many other states are. And they're back in full lockdown with nightly curfews, 24-hour lockdowns, and only essential travel. So in summary, the debt crisis was caused by policies which the island had no say or input in, and now the restructuring is doing the same way. The health crisis was due to eliminating the public healthcare system for a private system without a backup. And Maria was a very predictable disaster with a healthcare system that was already badly decimated. And it's just an example of the dangers of what happens when capitalism and corporate self-interest run crazy, which is a lesson the rest of the United States really needs to take care in terms of these neoliberal policies. And with that, I'll hand it over to Steffie to present. And you may be on mute, Steffie.
Yes.
Now I can hear you.
This one right here. No, it's here, isn't it? How do I? Hi, yes, I'm Steffie Woolhandler, and I'm going to be talking about the role of the healthcare system in creating the mortality crisis in the United States. We've never had fewer than about 25 million uninsured people in the United States. Obviously, the ACA didn't eliminate the problem of the uninsured, but since the COVID pandemic, we've seen a huge spike in the number of uninsured. Nobody's really sure how big it is. It's somewhere between 7 million and 13 million additional uninsured Americans. In addition to people who are uninsured, a large share of the population is underinsured. For instance, folks who have insurance they can't afford to use because of their very high deductibles. About half of privately insured people have a very high deductible now, and most of them do not have any sort of health savings account to let them pay that high deductible. It's defined on an annual basis, but it's currently about $1,350 would be considered a high deductible. Persons who are underinsured, like those high deductibles, similar to people who are uninsured, are more likely to delay seeking care when they have the symptoms of a heart attack. Underinsured persons are 21% more likely to delay seeking care. Uninsured 38%. Even co-payments for things like medications can have lethal consequences. In this case, drug co-pays in this randomized controlled trial increased post-myocardial infarction vascular events. So recurrent events after MI are increased when the insurance plans include large co-pays. Not terribly surprising to someone like myself, a primary care internist. We've also seen tremendous bureaucratization of the U.S. healthcare system, with the growth of administrators exceeding the growth in physicians or nurses, for that matter, many-fold. A lot of that is accounted for by our private health insurance industry, which has made giant profits off of the COVID pandemic because people are using less care because of the pandemic. Less elective care, and that's made a lot of money for the insurance companies who continue to charge high premiums. Some of this shows up as the huge salaries of CEOs of insurance companies, pharmaceutical companies, or as the huge profits overall in our for-profit healthcare industries, most prominently the pharmaceutical industry, $84 billion in profits last year, but insurance companies as well, taking home about $24 billion last year alone, and as I pointed out, likely to go up this year. It turns out that of the total healthcare system in the United States, about 2/3 of it is actually funded through our taxes as taxpayers. We're not only funding Medicare, Medicaid, VA, we're also paying for the benefits of government workers and the so-called tax subsidy to private insurance, which is the money lost to the federal treasury because health benefit costs are not taxable as compensation. And looked at that way, it turns out that the taxpayers in the United States are already paying $7,600 annually in taxes for health care, and then turning around and paying another $4,000 annually privately. Indeed, our tax-funded share of health care in this country exceeds total health care spending, public and private, in all other nations with the exception of Switzerland. We're already paying the full cost of national health insurance, we're just not getting it. Now, what do we get for this extra money? We are not getting longer life expectancy. We die 2 to 3 years shorter than people in other nations. We're not getting better infant mortality. Infant deaths are twice as high as in parts of Europe. We're certainly not getting lower maternal mortality. Maternal mortality for all ethnic groups in the United States exceeds average maternal mortality elsewhere in the world. We're not getting profligate use of medical services. Americans visit their physicians less than people in other countries. They spend fewer days in hospital because they go home quicker and sicker. The high costs are not due to bad habits. Americans do not smoke more than other nations, nor do we have a higher share of elderly people driving up our costs, nor is our immigrant population responsible for our costs. We have fewer immigrants than in many other countries. Moreover, the immigrant population almost certainly makes healthcare more affordable to other people. In this work we published in Health Affairs, we found that immigrants were in fact keeping the Medicare Trust Fund afloat through their payroll tax contributions as healthy workers and then not using Medicare when they aged. Turned out the same is true for private insurance. Immigrants who tend to be healthy young workers are subsidizing the rest of us within the private insurance industry. Now, what we are in the United States getting more of is things like insurance overhead, $815 per capita in the United States. Much of that high insurance overhead is paid for by the taxpayers through Medicare and Medicaid. In 2017, Medicare, shown in blue, and Medicaid, shown in yellow, together accounted for well over half of total private insurance revenues in the United States. So that overhead is being borne not just by private payers, but by the taxpayers as well. We're quite familiar with the Medicare Advantage plans, but their overhead at more than 14% is about 7 times as high as overhead in the traditional fully public Medicare program. And because of that high overhead shown in yellow on this slide, the fact that Medicare Advantage is able to cut the amount of medical care that seniors receive is more than counterbalanced by that high overhead, leading to higher costs for American taxpayers because of the private participation in the Medicare Advantage program. Now, what are our alternatives? We tend to talk about the Canadian system. It provides universal coverage, portability of benefits from place to place, coverage for all medically necessary services, and a publicly administered nonprofit plan. And what happened in Canada is they were able to increase the share of people with serious symptoms who were able to see a doctor from the before the program to after the program. In the modern language, they were able to increase the use of high value care by making healthcare free at the point of use. They were also able to drop their infant mortality rate well below that in the United States. And in some ways, the most convincing study I've ever seen on this was a study on cystic fibrosis that appeared in the Annals a few years ago, where there's a very careful comparison using registry data of mortality of cystic fibrosis patients in Canada versus the United States. And it's fairly obvious to me that cystic fibrosis mortality is very closely linked to the adequacy of medical care. And yet cystic fibrosis mortality in the United States was 52% higher than similar patients in Canada. And this was true regardless of the type of insurance that Americans had. Now, Canada has not soaked their medical workers or physicians. The physicians' pay is very, very good. And yet they have succeeded in controlling their healthcare costs, expressed here as a share of GDP, where you can see the costs diverging in the United States and Canada at the moment where Canada enacted their national health program. Where does Canada save money? Well, they save money on that insurance overhead. They save money on hospital billing and administration, which costs more than $1,000 per capita in the United States. They save money on doctor's office billing and administration, all that paperwork we do in order to get paid. Overall, they save more than nearly $3,000 per capita on administration, which is the money you need to provide universal health care to everyone and take the people who are now underinsured and improve their health coverage. For any level of spending, a single payer Medicare for all system will purchase more care and less administration than mixed public-private systems, including the public option, which Joe Biden has been talking about. That was the conclusion of the study in the Lancet from Galvani and Fitzpatrick, showing that universal coverage under single payer is substantially cheaper than a multi-payer system. But even these studies of the costs of Medicare for All, which you may be more familiar with, all of them have shown that the administrative savings of a Medicare for All system would allow you to maintain and actually slightly increase the amount of money spent on physician and other outpatient care. You can't see it, but there's supposed to be a line there showing a 100%. That's the cost in the current system. And all of the estimates you've been hearing about, Mercatus, Rand, Urban Institute, and if you're up on things, the latest CBO estimates, all of them show that the efficiency of the Medicare for All system would allow continued and actually slightly enhanced spending on physician and outpatient care. Polls are showing increasing support for single payers, shown in yellow on this slide. And similarly, looking at the physician community, we've seen a tremendous increase in the support within the physician community for the concept of Medicare for All. So why don't we have it? Well, our big problems are sort of illustrated here. This is a view from Cambridge, where I used to live, over the Charles River into Boston. And you'll see our two get the Medicare for All system that the American people want and deserve. Okay, so this is the end of the formal presentation. So would you like us to take a few questions, Olveen, or would you like to make a few remarks?
I'll let Roy usually at the end of grand rounds ask the questions. There may be a plant in there, but I will end it off to Roy Weiss.
I want to thank Professor Himmelstein, Woolhandler, and Carrasquillo, and Dr. Bailey for an absolute outstanding series of talks and grand rounds. I want to first give a special welcome to Dr. Bailey. She's only been on the faculty for 2 months and already has had a major impact in the way we think and what we think about. And so, Zinzi, we welcome you with open arms, and we're glad that as 2020 ends down, we have many bright spots, and you're one of them for the beginning of 2021. So again, thank you all. Maybe we could ask, where are the opportunities for us as physicians to affect the changes that are so necessary? If you had to, because we'll ponder all of this, of course, but it's really the action that is what is required. And as physicians in our practices and so forth, if you had to give us the top 2 or 3 things to do, and this can be directed to any of the speakers, what would it be?
Well, I would tell people to engage in some of these struggles. I think physicians have a special responsibility to engage in talking about ways to reform the healthcare system, but physicians also need to be speaking out against racism, against anti-immigrant sentiment, against colonialism. So the physician community continues to have tremendous moral stature, particularly when we talk about something other than our own pay. People want to hear from us, want to be reassured by us that that change is possible, that change would actually improve health. So I would just really encourage people to engage with organizations fighting for change.
I'll add that there are a number of things we can do in our own institutions. So we continue to have marked underrepresentation of people of color in our professions, and we ought to be addressing that with our admissions policies and support within our institutions. In many hospitals, I don't know about in Miami, but in many hospitals, the people of color experience care largely from residents, whereas wealthier, mainly white, non-Hispanic people get care from staff physicians. We ought to integrate the care more fully within our institutions, and we ought to lobby for the resources that our safety net institutions need. So I think within our own milieu, we need to make change as well.
Thank you very much. We are at the top of the hour, and there's lots more that can be said. We look forward to a brighter future, but personally, I want to wish each and every one of you a very safe holiday season. This concludes our grand rounds for 2020. I'll look forward to seeing you all back healthy and happy in January. So please be safe over the holidays. Peace and justice to everyone.
And please note the link in chat for the CME and MOC credit, as well as the QR code. Thank you.
Thank you, David and Steffi. Thank you so much for doing this.
Thank you, Olveen.
Great. It was very interesting. Great.